Hello, everyone. So as we're filtering in, give us just a moment. Thank you all for joining us. Looks like we have everybody in and we'll have a few more trickling in. So hello, everyone. My name is Lizzie Stewart. We are pleased that you could join us for this week's lecture in Volume 11 of our No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. Additionally, No Neuropsychology works to bring you discussion questions that are provided with specific lectures content. You can access these on our website. Here are the disclaimers for this series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my great pleasure to introduce Iman Rettig for today's lecture entitled An Alternative Approach, Risk-stratified Neurocognitive Monitoring in Pediatric Oncology. Dr. Iman Rettig earned her doctoral degree in clinical psychology at Wright State University School of Professional Psychology in Dayton, Ohio. She completed a one-year APA-accredited pediatric neuropsychology residency at Dell Children's Medical Center and Dell Medical School at the University of Texas at Austin, in Austin, Texas. She then completed her two-year APPCN-accredited pediatric neuropsychology postdoctoral fellowship at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Currently, Dr. Rettig works as a pediatric neuropsychologist at Children's Health Medical Center and serves as an assistant professor of psychiatry at the University of Texas Southwestern Medical School in Dallas. In her clinical role, she works within the Center for Cancer and Blood Disorders, conducting outpatient neuropsychological evaluations and clinical research. Dr. Rettig specializes in acquired and traumatic brain injuries, brain tumors, cancers, hematological conditions, disorders of consciousness, and neurodevelopmental disorders like ADHD and learning disabilities. She also has a special interest in conducting psychotherapy and intervention in the areas of behavior management, parent management training, and habit reversal training, as well as executive functioning. Lastly, culturally responsive neuropsychology practice is imperative to Dr. Rettig's clinical research and scholarly work. She is consistently working on her own cultural humility, embedding culturally responsive practice within training and speaking on how to translate theory into practice. And with that, please help me welcome Dr. Rettig.
Thank you for that warm welcome, Lizzie. Let me share my screen here. You can let me know how that looks.
All good.
All right. Well, thank you again. I have been watching No Neuropsychology's lectures practically since its inception, and I've also used them as supplemental materials for my trainees. So I'm absolutely thrilled to be presenting on the No Neuropsychology platform. Let's get started. Objectives for this presentation include briefly introducing aspects of the field of pediatric oncology as it relates to neuropsychology's integral role within that field. Next, I will discuss cognitive late effects or cancer-related cognitive impairments, which will lead to introducing risk-stratified neurocognitive monitoring. Then I'll demonstrate a few ways to implement risk-stratified neurocognitive monitoring for pediatric oncology patients. Starting with current trends in pediatric oncology. Most common types of cancer diagnoses in 2016 to 2020 were leukemias, followed closely by malignant brain tumors, lymphomas, different types of neoplasms and melanomas, among other soft tissue tumors and other types of bone tumors. Notably, the incidence rate was estimated to be around 15,000 for new cases and about 1,600 new deaths in 0 to 19-year-olds in 2024. What we know is that cancer is the leading cause of death by disease after infancy among children in the United States. Now, survival rates have dramatically increased, and this improvement has been especially notable for patients diagnosed with acute lymphoblastic leukemia, or ALL, which has a 5-year survival rate of 92.3%. This happens to be the most common childhood cancer, so this is really, really exciting for the field. The advancements in therapeutic treatment modalities have involved contemporary therapies that favor radiation-sparing regimens and risk-adapted protocols. And although treatment advances have made significant improvements in children's healthcare outcomes, these life-saving treatments continue to result in cancer-related cognitive impairments, even when omitting cranial radiation and when using chemotherapy-only protocols. So, an increased survival rate means an increased need for clinical monitoring across disciplines and especially within neuropsychology, considering the early onset of some of these diagnoses. As neuropsychologists, we know that early childhood is critical period for neurodevelopment. And a notable neurodevelopmental change that is taking place during early childhood is the directionality and efficiency of white matter connections throughout the brain. Unfortunately, it's often the case that patients are receiving these intensive treatments during early neurodevelopmental periods, which is subsequently impacting brain development. So, what is neuropsychology's role within pediatric oncology? Briefly, neuropsychologists are typically involved in evaluating patients with primary neoplasms of the central nervous system and cancers of other organs that can affect the central nervous system, either directly via brain metastases or as a result of treatment, such as neurosurgery, certain types of chemotherapy, or cranial spinal irradiation. So, what does that really mean? Well, we're typically seeing patients with cancerous brain tumors, non-cancerous brain tumors, cancers of bone marrow and blood, and that's because those cancer cells can build up around the brain and or the treatment that's used for those types of cancers can cross through the blood-brain barrier. We're also seeing patients with other types of cancers of other organ systems that can spread to the brain. So think about if a patient has cancer of the kidney or the liver, and then it spreads to the brain as well. We're also seeing patients who have had neurosurgery, certain types of chemotherapy, and cranial spinal radiation. Now, what does that look like in practice? Well, some of those referrals may include, like I've mentioned, ALL, which is a cancer of the bone marrow and blood, medulloblastomas. These are fast growing cancerous brain tumors. We also have craniopharyngiomas, which are brain tumors, but they're termed not cancerous, pilocytic astrocytomas, and a whole host of malignant gliomas, which are cancerous brain tumors. Now, sticking with the theme of brain tumors, we can see acute neuroanatomical and neurological impacts. Think about it. We have this big lesion that's in the brain taking up space where it's not supposed to be. It can result in reduced perfusion, which subsequently can lead to an ischemic infarct or a hemorrhagic infarct. It can result in mass effect. That's when there's displacement or compression of brain tissue and structures because of the size and location of the tumor. Also, thinking about the size of the tumor based on where it's located, it can lead to obstructive hydrocephalus, for example. Now, some protocols may involve neurosurgery as the number one treatment option, but some other protocols may involve starting with radiation, for example, for brain tumor treatment. Now, with those patients, we can see leukoencephalopathy, white microvascular injury, as well as radiation necrosis too. Oh, got a little bit ahead of myself here. Okay, we're back on the right track. So, research has shown specific types of neuropathology that results from certain chemotherapy medications as well as cranial spinal irradiation. But let's briefly talk about chemotherapy. There are a variety of chemotherapy agents that have different classes or different categories. One of those categories is called an antimetabolite. One particular antimetabolite that happens to be used in many protocols is methotrexate. Methotrexate is an antimetabolite medication, chemotherapy agent that can cross the blood-brain barrier on its own, especially at high doses. However, it can also be administered intrathecally, bypassing the blood-brain barrier altogether. I have seen patients with acute neurological toxicity due to methotrexate. When I was working on the inpatient rehab unit, there was a patient who was in the consolidation phase of treatment, but needed to be hospitalized due to these acute cognitive changes that happened resulting from the chemotherapy toxicity. Most of the time, though, chemotherapy medications, and especially methotrexate, results in long-term cognitive impact due to the leukoencephalopathy. But more specifically, studies have demonstrated both increases and decreases in brain structures and functions, microstructural changes, including smaller volume in frontal, parietal, and temporal white matter tracts, as well as increased vulnerability in the functionality of the hippocampal formations and the frontal lobes. There's additional research that links cranial radiation and intrathecal methotrexate to smaller white matter volumes. This results in overall weakened white matter integrity, as well as injury to the corpus callosum. Now, if we're thinking about overall weakened white matter integrity, unfortunately, that's going to result in disruption in communication between specialized neuronal communities. Then we have to think about the gray matter. We can't leave that out. That has also shown to be damaged due to treatment, and damage to gray matter can result in disruption of specialized information processing at both the cortical and subcortical levels. So these neurobiological and structural changes oftentimes result in functional impairment in the form of cognitive late effects or cancer-related cognitive impairments. Cognitive late effects are the most common and life-changing sequelae of childhood cancer. It's essentially an acquired brain injury. There's a prevalence rate of about 35 to 60%, and the prevalence can be even higher in brain tumor patients. Most often, we tend to see cognitive late effects with an onset of about 2 to 3 years post-treatment completion, but patients can also have, as I mentioned, acute toxicity, or families can identify changes in cognition right after treatment completion. But most of the time, it's 2 to 3 years post-treatment. And when we look at the studies and when we look at how these medications are impacting brain development, we can see that it's resulting due to this injury to white matter tracts, gray matter structures. But if we're thinking about a biomarker level, some studies have demonstrated that there's increased inflammation, oxidative stress, altered folate physiology, and changes in epigenetics. I do want to highlight, since ALL is the most common childhood cancer, um, it's often the case that those patients can be treated with chemotherapy-only regimens, but those chemotherapy protocols tend to include methotrexate. So common cognitive weaknesses in those patients tend to be in the areas of aspects of attention and executive functioning, processing speed, and fine motor skills. But if we take a step back and look at cancer and cancer treatment as a whole, most common cognitive domains that are impacted include sustained attention, working memory, and processing speed. And now, if we're thinking about those cognitive abilities, you can very easily see how they can have a secondary or subsequent impact on an individual's academic functioning, their adaptive skills, the behavioral and emotional functioning, social skills even, and definitely future independence. There are several factors that contribute to neurocognitive outcomes, some that can be identified at the time of diagnosis, during treatment, and then once the patient is in remission and in the survivorship phase. So some factors to consider include age at diagnosis, specifically being age of 5 years or younger. Now, if you're thinking about this from a neurodevelopmental perspective, that makes a lot of sense, right? Because a lot of brain growth and efficiency, directionality, et cetera, is happening during this time. Female sex also happens to be a factor, as well as the patient's premorbid functioning. Where were they at? Where were they at developmentally? Did they have language or motor delays? Was there a complicated pregnancy? How were they presenting at the onset? And then there's cultural factors such as socioeconomic status, family functioning. What is the family's level of health literacy and their ability to access health resources? Some treatment factors to consider include the genetic polymorphisms, treatment exposure, their medical course, and acute neurological toxicity. Now, as I mentioned, these are very strong medications. So they're not only attacking the cancer, they go through different organ systems. So there are often times where you see patients that are hospitalized for several weeks due to acute kidney injury, and that they can have to deal with that after treatment as well. And some of those factors moving into survivorship include sleep, their level of physical activity, their stage of neurodevelopment, any untreated mental illness, any late effects from treatment, both cognitive or physical, their support in terms of getting back into school or occupation, their healthcare access and health literacy, and social support. So, how are we serving these patients? Most commonly, a population-based model is being implemented, and this involves all patients being referred for a comprehensive neuropsychology evaluation as standard of care. However, we are now learning that there are some drawbacks to this population-based model. First and foremost, the assessment of cognition starts after treatment completion. Now you'll say, Dr. Reddick, you said that cognitive late effects most often occur 2 to 3 years after treatment completion. Yes, that is in fact true. That is the case. However, we can sometimes identify cognitive changes even earlier. Also, if we're following that patient 2 to 3 years after treatment completion, it's very easy for these patients and families to get lost to follow up, have to wait around, and not end up getting care. So sometimes putting it off is not necessarily the best play. Also, a comprehensive neuropsychology evaluation may not be the right dose or the right sized care for patients. Some are at a high risk or medium risk for cancer related cognitive impairments, while others are at lower risk based on their diagnosis or treatment history. And those in the pediatric world know that comprehensive evaluations are time and resource intensive for families and providers. And as I mentioned earlier, with a significant improvements made in treatment outcomes, we as providers cannot necessarily keep up with the demands. And this is resulting in long wait lists, delays to accessing care, patients being missed completely, and general health inequities. So, what do we do? Well, in contrast to a population based model, a risk stratified model considers several important variables, including evidence based practices, patient and family needs, as well as provider resources. In contrast to a population based model, a risk stratified model starts during treatment. It's also risk stratified, meaning it has tiers of care that can be provided so that the patient can receive the right size care based on their medical history, subjective concerns, and objective or performance based results. It's also timely and efficient. It can start during treatment, or if things are going well, towards the end of treatment when we would potentially start to identify early cognitive changes. It also leverages resources such as being able to bundle questionnaires with other medical questionnaires, collaborating with our pediatric or health psychology colleagues, providing services in different settings, for example, within a multidisciplinary clinic, and using targeted cognitive screeners rather than our long list of batteries. It also helps by decreasing the wait list through efficient and evidence-based triaging. It increases access by offering different levels of care. And by doing all of this, it's improving health equity because we're increasing access to care, we're providing psychoeducation earlier, and we're providing access to hospital-based as well as community-based resources earlier in the journey. So Dr. Hardy and colleagues proposed a prevention-based tiered three-level approach to neuropsychological assessment, which was a notable advancement in the field. Dr. Jacola and colleagues from St. Jude Children's Research Hospital built upon that model by one, specifying the direction for implementation in pediatric oncology, Two, addressing the application of monitoring across contexts. And three, by offering a common language to improve intradisciplinary and interdisciplinary communication. Their evidence-based framework for neurocognitive monitoring begins during during therapy and continues into survivorship and looks like this. There are three levels: a primary level, a secondary level, and a tertiary level. The primary level is for all pediatric oncology patients within a clinical service, regardless of cognitive complaints or risk factors. So assessment at this level can be provided by the medical provider, a pediatric or health psychologist through open-ended questions or even structured questions. They may even use a structured questionnaire. Dr. Jacola and colleagues also highlighted that performance-based measures could also be used at this level and would need to focus on attention, executive functioning, working memory, and processing speed. Some examples they gave in their article include the NIH Toolbox, the COG state, or the impact. Ultimately, the goal of the primary level is to provide psychoeducation about developmental milestones, provide psychoeducation about neurocognitive late effects, strategies for improving adaptive skills, and really providing access to center-specific resources. The secondary level is for patients with subjective cognitive complaints, for those who present with risk factors for neurocognitive difficulty, and or for those who perform poorly at the primary level. Assessment at the secondary level would include being either administered by a neuropsychologist or even a pediatric psychologist based on how they're explaining the model. So assessment can include standardized questionnaires and performance-based measures in select cognitive domains. Based on how much time you have in your clinic, you may give a 2-subtest WASI, a working memory processing speed subtest, maybe do the PPVT and word reading, some other areas. Ultimately, the goal is to determine eligibility for early childhood intervention, provide school reentry and academic support, such as helping with providing documents to obtain a Section 504 plan or IEP. And then the tertiary level is for patients with pre-existing neurocognitive deficits and for those for whom a comprehensive assessment is warranted based on the referral question, diagnosis, and of course, if they perform poorly on the earlier levels. So this is your tried and true comprehensive neuropsych evaluation. And at this level, based on where the patient is at in their treatment, the goal may be rehabilitation, determining if that's needed, supporting school reentry or behavioral intervention plans, bulking up an IEP, determining differential diagnoses, and supporting overall medical treatment planning. So using a risk-stratified model is critical because regular monitoring supports early detection of cognitive changes. And early identification of cognitive weaknesses, that is before they have a significant functional impact on daily functioning, facilitates remedial opportunities that can actually translate to improved outcomes and quality of life. Now, I'll take some time to share how I have gone about developing and establishing risk-stratified neurocognitive monitoring in my institution. I recently started at my current institution and quickly began learning about the hospital as an organization, the oncology department structure and goals, existing neuropsychology practices, and strengths, as well as potential areas of clinical improvement. Major strengths of my institution, as well as the oncology and neuropsychology departments, are that they are committed to evidence-based care and are ready to evolve as needed to do just that. So I know that I'm fortunate to have the support for this big clinical and research program initiative. So within our oncology department, a population-based model was being implemented. Again, nothing wrong with that. But as I previously demonstrated, we can do more. plus the Psychosocial Standards of Care Project for Childhood Cancer and the Children's Oncology Group guidelines highlight the need for systematic and interdisciplinary neurocognitive assessment. So I got to work to determine how to apply this risk stratified and tiered approach to the organization that I was working in based on the resources that I had access to. This took some time. I needed to meet with stakeholders, and that included neuropsychology leadership, physician leaders, and a whole host of medical providers because we have a lot of clinics here at Children's Health in Dallas. There are several providers that are providing treatment and services to patients who are on treatment and those that are off treatment. So it's important for me to know who is in which clinics and have a better understanding of what the needs are from a neuropsych perspective. So that was really important in terms of like a needs assessment. So after these several discussions and consultations, it was determined that the best point of entry into this system to be able to establish this tiered model of care was in the survivorship clinic. So as I mentioned, and for those who may not be familiar, survivorship is when the patient is in remission. Different hospitals have different definitions of survivorship, and sometimes even within the hospital, it can vary on a patient-to-patient basis, just based on the complexities. Here, patients typically stay on their on treatment in their on treatment clinic for 2 to 3 years, and then will transition to survivorship afterward. So I know that I mentioned that the risk stratified neurocognitive monitoring model prides itself on starting during treatment, and that is the goal. I will get there. It's just that based on understanding the system that I'm working in, the survivorship clinic is the best point of entry. So that's where I'm starting. That's where I'm developing these new processes. And so far, everything's working really well. So let's talk about what our version of risk stratified neurocognitive monitoring looks like. We have three-ish tiers. I'll focus on the solid 3 tiers, and I'll mention the other ones as they come up and if anyone has any questions about it. So tier 1 is a universal monitoring questionnaire. We have a parent/guardian questionnaire and a patient questionnaire. These are parallel. So each question that is on the parent/guardian form is also on the patient form. And also we're being mindful of how we're asking these questions. The questionnaire is focusing on specific cognitive domains that are at risk that we know based on the literature. The goal, which we are soon to reach, is to have it disseminated electronically. And last but not least, we have to consider language. Here in Dallas, Texas, we have a very culturally and linguistically diverse patient population. So in the development of this questionnaire or in the selection of a questionnaire that you determine to use, we need to be very mindful about whether or not there are existing translations of that questionnaire. And if there's something that you're developing on your own, how easy is it to translate it into another language? Are you still measuring the same construct? What is the validity, the reliability of these questions? So these are all issues that we need to consider. So that's our level 1, or sorry, tier 1. Tier 2 is a targeted cognitive screener. So this is something that I will administer to the patient during their survivorship clinic appointment. The targeted screener focuses on attention, executive functioning, processing speed, and memory. And then, of course, as I mentioned, we need to take culture and language into consideration. Just as a side note, here in Texas, the most common non-English language that's spoken as a primary language of households is Spanish. And that is followed by Vietnamese, Mandarin, and then Cantonese. I do speak another language, but it's not any of those 4. So I'm an English speaking provider. And when I'm choosing my measures, I need to make sure that I'm being mindful of that as well. So when I'm conducting my brief clinical interview and there's a patient that might be bilingual or multilingual, it's important for me to determine their level of English proficiency. And that will include Asking questions about language development, like we all do. So, what languages was the patient exposed to first, second, or third? What context are they using this language in? What language did they start say their first words in? What language are they getting their education in? It's very common here in Texas that patients may have, preschool through middle school in Spanish and English. They're getting bilingual educational instruction, but then from middle school onward, they may have English only instruction. So these are important considerations to make when you're thinking about the patient's age, what grade they're in, their language development, how comfortable they feel speaking English or whatever the other language may be. So if I determine that the patient has adequate English proficiency, I'll go ahead and administer the targeted cognitive screener in English. If that's not the case, that's when we have this tier 2.5, where I will refer them to a different step so that they can still be screened and still have access to care. I have seen patients in the clinic that are monolingual English speakers, so I'll do my best to make sure they also get to that 2.5 level so that they can get services as well. And then our tier 3, this is a comprehensive evaluation that's going to be tailored to the unique patient characteristics and needs. And I'm primarily assessing for cancer-related cognitive impairment, but of course, other things come up. There's other differential diagnoses. The family may have some concerns, provider may have some concerns. So we need to be comprehensive in that nature. And this is going to take place in an outpatient clinic. And again, I'm highlighting the cultural and language considerations. Our department does do some triaging based on a questionnaire to see, can the patient be seen by an English speaking provider, even though they might be bilingual, or is this a monolingual Spanish speaker that needs to be seen by a Spanish speaking neuropsychologist, and different considerations that are made along those lines. Okay, I'm going to provide some additional details regarding our tier 1 and tier 2. So tier 1, we are using a universal monitoring questionnaire. This is different from what Dr. Jacola and colleagues highlighted in their article. And again, it's going to be different based on the institution, resources, needs, etc. And that's okay. So in their article, they said that a medical provider or a pediatric psychologist could answer open-ended questions or use structured questionnaires and even administer a performance-based measure. And if you can do that, that's amazing. The way our clinic is structured, we don't necessarily have access to those types of resources. So we do have a medical provider, of course, but they're already doing a lot, and we don't want to add burden to their plate. And they're looking to neuropsychology to be able to ask the right questions to get the help that these patients need. We also don't have a psychologist in this clinic, so we were going to be crafty in how we went about making sure we're screening all the patients. So first things first, we decided to go with a questionnaire, but we had to determine which questionnaire to give. There's a lot out there. And I started researching existing questionnaires, evaluating their psychometrics, their applicability to the patient population I needed to focus on, and of course, their clinical utility, among other variables. And there are a variety of existing standardized questionnaires, some that are developed for pediatrics, some that have been validated in pediatric oncology populations, and that was really nice to see. Some of the questionnaires I came across were the PEDS-QL, the PROMIS, specifically the short form, the PROMIS perceived cognitive functioning, the belief, among others. And these are really nice questionnaires. But as I evaluated them in clinic, I noticed that there were a few areas that I would like to have some changes or improvements in. I did want to give them a test drive, so I started using them in clinic. And I noticed that some of the questionnaires I was able to get some useful information. Some of them had a little bit confusing phrasing. Others, the patients and families were noting they weren't a fan of the anchor points, and some were just frankly way too long. So what I needed was a questionnaire that was brief. It was going to focus on the cognitive domains that were at risk. It was accessible at low literacy levels. There were parent/guardian and patient parallel forms. And of course, that it could be translated into multiple languages or had existing language translations. So I wasn't getting what I needed out of the questionnaires that I was using. And my dear colleague and I decided to create our own. So we went about and did that. Um, Developing a new patient questionnaire in clinical or research settings requires a systematic evidence-based approach to ensure that the instrument is going to be reliable, valid, and ethical. And there's a process that we've been following to ensure just that. I'm going to highlight some of those processes here. So first, there's a needs assessment. What are the needs here? And what is the objective definition of what we want to be measuring? Then we move to the literature review and analyze the existing instruments. So I was looking at all the instruments and all of their items to see where are they asking about attention, initiation, processing speed, working memory to make sure they were hitting on all those areas. Then I had to look at the construct definition and theoretical framework that it was tied to make sure that what I'm developing is tied in theory. There's also item generation to make sure we are correctly creating items that are tied to the right constructs. Expert review and content validation. This is an ongoing process. I shared it with my colleagues, got a lot of feedback, administered in clinic, revised it, piloted it, revised it, and piloted it. That's a little bit of mix of that pre-testing and pilot testing. And right now it's in a good place and it's at the point where it is ready to be disseminated via electronic medical record so that patients can actually complete it prior to coming to their survivorship appointment, like kind of like at their check-in, which is really, really exciting. That's when we're going to be able to start collecting data and doing some validation studies to improve its psychometrics. And we'll continue to do that until it's in a really, really good place. So look out for that manuscript in the near future. Oh goodness, I did it again. Okay, here we go. So diving a little bit deeper into the tier two targeted cognitive screening. So I needed to figure out what am I going to give? And I started working on this almost simultaneously, collaborating with colleagues, asking questions about what they use in their clinic or what they had heard, worked for them, looking at what was being used in the research, and also looking at the existing resources that I had access to. So some of the ideas that were given in some of the articles include the COG state, the NIH toolbox, cognition battery, the impact, the attention network test, the AMPAS, among some others. Based on how much time you have in your clinic, you could do a little bit of a longer battery, maybe an hour, maybe 90 minutes, and where you could get an abbreviated IQ and do a little bit more of a lengthy testing. But again, that depends on your setting and what you can do. My setting, I needed something that was brief, that I could quickly administer, quickly score, that was focused on the right cognitive domains, that had good sensitivity and specificity so that I could appropriately triage patients, and that had the opportunity to be translated into multiple languages. So when I was talking about to the stakeholders about entering into the survivorship clinic, it was not multidisciplinary. So me entering in kind of helped create that aspect. But without me there, the patients had a lot going on in these appointments. They're checking in, which believe it or not, takes some time. They were going to phlebotomy for updated labs. They met with a nurse for nursing basics. Then they met with a medical provider that took some time. They might meet with a researcher, which takes additional time. Then they have to meet with another nursing specialist. So on average, these patients are here for 2 hours, maybe more, maybe sometimes not even less. So what I was wanting to do, if I'm going to enter into the system, I don't want to create extra burden for these patients and families, as well as create extra burden for my team, right? I want to be efficient with my team. I want to see if I can make use of the patient's downtime if they have any. And in conversation, I did learn that they have a good amount of downtime between everything. And we could structure things a little bit differently and be a little bit more routine so we could make these visits really efficient for the patients. So currently we're doing just that. And my visit is on average 40 to 45 minutes. I'm trying to get it to be a little bit shorter, but even with my visit, it's not exceeding that 2 hour mark. I'm just making use of some of the downtime they have. On the shorter end, it could be 35 minutes, and I think that's a nice sweet spot. All right. Just a few more slides before we finish up for today. I want to contextualize the model that I have established and implemented to provide a little bit more context and make it a little bit more real through some case examples. The following case examples are fabricated, but are broadly based on a variety of clinical cases. And you'll see I write brief at the beginning of everything here because it is very brief for the sake of this presentation. I'm just going to tell you some basic facts that you need to know to broadly conceptualize this information. So in my chart review, I learned that this patient was a 15-year-old right-handed English-speaking Black male who was diagnosed with pre-B cell ALL at age 3. He received chemotherapy only that included a variety of chemotherapy agents, one of which included the administration of intrathecal, intravenous, and oral methotrexate. He completed treatment at age 6, and at the time of the patient's current appointment, he was about 9 years post-treatment completion and had never had any contact with neuropsychology. Just all the more need for this tiered model. Okay, so I did a very brief clinical interview. This is not the only information I gleaned, of course, but just want y'all to know the parent and the patient both reported long-standing attention and math concerns. And when I dove in a little bit deeper, I was able to learn that regarding the math piece, it was more difficulty with remembering formulas and then being able to execute what the formula was asking in the right order. That was hard for this patient. So based on the patient's diagnosis and treatment, he would automatically get the Tier 1 universal monitoring screener. So I administered that. And the patient endorsed concerns about attention and working memory. And the parent also endorsed concerns about attention and working memory. So they were on the same page, and that was really nice. Now, based on our universal monitoring screener, we do have a scoring criteria, and based on how the patient endorsed and the parent, that would trigger triage to Tier 2. So I went ahead and administered the targeted cognitive screener. And some of the patient scores were broadly within normal limits for short-term memory, but there were a number of areas that were areas of concern or where the patient had lower scores. So these were on the tests of attention, processing speed, executive functioning, and contextual verbal short-term memory. The patient's total score was suggestive of mild neurocognitive dysfunction based on the screener that I used. So I do have the parent leave the room and then come back during the testing, and then they come back. And at that time, I share the results with the patient and the parent. It's a really good time for psychoeducation. I do that at the beginning as well, but just as a reminder, a recap to contextualize the scores and the information that I'm giving them. And based on that, they were on board and ready to schedule their Tier 3 comprehensive neuropsychology evaluation. Okay, this next example, some information that I was able to retrieve from the chart review. This is a 12-year-old right-handed bilingual Spanish and English speaking Hispanic female. She was diagnosed with also pre-B cell ALL at age 6 and had chemotherapy only. And that included the administration of intrathecal, intravenous, and oral methotrexate. She completed treatment at age 9. And at the time of her current appointment, she was about 2 years post-treatment completion. So this was her first survivorship appointment after being discharged from the on-treatment clinic. So this was really exciting. In the clinical interview, I did ask those questions about language development so I could determine English proficiency and broadly level of bilingualism. The patient's early language and motor developmental milestones were on time. Her first language was English, second language was Spanish. Spanish was more conversational. She had never received education in Spanish, and she mostly used it with her elders, so aunts, uncles, grandma, grandpa, those family members. And so that in that regard, I felt comfortable going forward and administering the next parts in English. At the time of the appointment, the patient was a sixth grade student and reported difficulty with reading and reading comprehension, as well as reported a lot of worries around progressing in school, mainly due to her reading difficulties. Again, based on the patient's diagnosis and treatment, she would automatically get the Tier 1 Universal Monitoring Questionnaire. So I administered that to her, and she endorsed concerns about working memory. The parent did not endorse any significant concerns. Everything was like a zero. This is interesting, right? Good to know. Based on how the patient answered, and because of our scoring criteria, it did trigger a Tier 2 targeted cognitive screener. I went ahead and administered that and had really interesting results. So, spatial short-term memory, broadly normal, but areas of concern were in every other area that I tested. Her processing speed, very slow. Inattention, difficulty with executive functioning and impulse control. Her verbal short-term memory, she had a really hard time just learning simple information and remembering it later. This, and sorry, and her total score based on the screener was suggestive of significant neurocognitive dysfunction. So as you can imagine, seeing how the parent responded, this could be a shock to that parent and was really a great time for psychoeducation. And I'm so happy to have set it up that way because I want to share it in a way the parent can hear it while the patient is being validated about their concerns. And when you describe the areas of concern that the patient had on testing, I gave examples that the parent might have seen at home or at school or when they're observing their child with friends. And slowly but surely, the parent started to notice that, oh yeah, that is hard for her, or she does struggle with that sometimes. And said things along the lines of, I didn't realize it was that hard for her. This just highlights the need for multiple reporters. And I think it's very important to do a parent/guardian questionnaire as well as a patient questionnaire. Patients can sometimes have awareness and insight into their difficulties while the parents don't, because they may just be grateful that their child is alive at this point, given everything that they've been through. So this is working. It's going really well. We're getting really nice results and really good feedback from patients and families. So I'm really excited about the progress that we're making in this area. Now, just to recap everything as we finish up here, what am I doing? Who am I serving? So basically, I am serving patients with cancerous and non-cancerous brain tumors, those who have cancers of organs with brain metastatic disease, those who have cancers of other organs but also receive CNS-directed treatment, and for those patients who receive neurosurgery, specific types of chemotherapy, and cranial-spinal radiation. What am I doing? I'm providing risk-stratified neurocognitive monitoring using evidence-based and culturally responsive practices. Where am I doing this? In different settings. So soon I will be administering our universal questionnaire electronically. I'm providing services in a multidisciplinary clinic and in an outpatient clinic. When are we providing these important services? As I mentioned, Tier 1 is going to be prior to the survivorship appointment. Tier 2 is during the survivorship appointment. And Tier 3 is during the patient's outpatient clinic visit. And why am I doing this? As a neuropsychologist, my mission is to provide evidence-based and culturally responsive care to all patients and families. And using a risk-stratified and tiered approach allows for early monitoring of cognition, which can lead to early identification and intervention. As we all know, early identification is crucial to support patients' ongoing cognitive development and subsequently aspects of their academic development, behavioral, emotional, social functioning, adaptive skills, and of course, their future independence. So using a tiered approach that is the right-sized care for patients based on their risk offers timely and efficient care It reduces time and cost burden, and it also utilizes evidence-based triaging to leverage our existing resources. All of that together ultimately increases access to care and improves health equity. I hope this provides a clear and detailed and practical perspective for translating theory into practice and provides insight regarding different ways neuropsychology can practice within institutions to support health equity for all patients and families. These are my resources, and I'd be happy to take any questions.
Wow. Iman, thank you so much for your presentation. This has been excellent. And as somebody who also works in a pediatric cancer organization at a hospital here, I know this has been very helpful for us. So we do have a few questions. First, some of our audience was curious about mood measures involved in your universal screening questionnaire. So do you have any assessment of anxiety, depression, maybe even trauma, things like that in that assessment at any of the tier levels?
That's a great question. Tier 1 Universal Monitoring Questionnaire does not ask about any mood concerns. We are strictly focusing on cognitive issues at a broad level. We're just trying to capture as many and screen as many patients as we can. However, during the tier 2 targeted cognitive screener, in my brief clinical interview, I am asking questions about mood, anxiety, depression, trauma, etc. Oftentimes, it is the case that there's some type of medical trauma or whatever it may be. So that is definitely an important piece to the puzzle. And I do feel grateful that I have, as a psychologist, obviously, if something comes up, I'm going to do that, risk assessment and make sure the family can get access to resources. If something like that were to happen, we do have psychologists that can consult with us and be on call to check in. But that's a great question. Thank you.
Yeah. We were also, I think you kind of touched on this a little bit about just having some other folks available. But I'm curious about any other barriers that you might have faced while bringing this into fruition. And was there any, could you speak a little bit more to advocacy and
Mm,
how that helped in your role of bringing this, having this come to pass?
yeah, that's a big question. I will go back to my organization. So part of my job and my job talk actually for this presentation was to implement this risk stratified tiered approach. That was the ultimate goal. And I'm happy to share that like the neuropsychology department and the oncology department were very on board. So I have a lot of support in making this happen. With that, that doesn't mean there aren't going to be challenges, right? Because it's a new program, it's a new initiative, and I was also just learning how the system worked. So, sometimes there might be small obstacles regarding scheduling and billing, for example. I think one thing that may come up a lot is what codes do you use? And that's something that as an early career nurse psychologist, I'm still learning that. But how do we make sure that not that it's worth our time, but that we're being appropriately compensated for our time and we can demonstrate that and be appropriately rewarded for that while continuing to provide access to these services earlier on in treatment. So those are some things that I've talked to with my leadership about, and we've been able to work through that and be able to continue providing services and make the most of the care that we're providing.
And you already touched on this as well, but we did get a couple of questions about billing costs and maybe what billing codes or behavior codes you were using.
Mhm.
And then another person had asked if you could share a little bit more on the process. Oh, sorry. Curious how billing practices in tier 1 and tier 2 differed.
That's a good question. So tier 1 is going to be electronically administered. So
Mhm.
to my understanding, there wouldn't necessarily be a bill for that because it's a questionnaire that they're getting and completing. Tier 2 right now, based on how things are working at in my organization, that is a 96116, 1 unit. Um, I know that we've talked about health and behavior codes as well, and that's another option. So we're really, because it's in its infancy, trying different things and making sure that we are doing everything within the ethical guidelines as well as clinical guidelines to make sure we're, um, crossing our I's and dotting our T's while still giving patients good care.
Absolutely. Um, and just like you mentioned, there's a very fine line that we frequently have to walk of trying to make sure that we're being compensated appropriately, but also making sure that we're able to provide the highest quality care. Um, as part of that, like providing that quality of care, we were hoping you could share a little bit more on the process of tier one and tier two and how these like quick screenings during clinic, how these might differ from your work in just an outpatient clinic.
Yeah, that's a great question. Um, so tier one right now, before it gets to be electronically disseminated, is essentially 7 questions that the parent or guardian will complete and 7 questions that the patient will complete based on their age and, of course, reading level. So that is very short, as you can see. Tier two, I'm using the AmFast currently, and that's like 10 minutes start to finish. So that's really, really quick. So in the tier two appointment, the patient will come in, I'll go over consent, confidentiality. I'll do a spiel about neuropsychology services, cancer, the potential for cognitive late effects, things like that. And then I'll ask some of your typical interview questions and then hone in a little bit more on cognition and school to get a little bit of an understanding of how we might see that functional impairment playing out on the day-to-day basis. And then I will administer this quick and dirty questionnaire, give the results, and then you're done. Versus my tier three, my testing is maximum 4 hours and really around the 3 hour mark, 3 to 4 hours time with breaks. And that's obviously going to be different from a like 30 to 40-minute visit. But during that time, I'm able to dive in deeper using many more standardized measures, of course, to dive in and look at attention, processing speed, memory, whatever it may be. And then, of course, using parent questionnaires to get a school questionnaires as well to get an idea of how the patient's functioning in different settings.
Mhm. You had mentioned giving some of those results live to those
Mhm.
patients. Do you ever give recommendations in the same time or in that same visit?
Yes, absolutely. So I really approach patients from more of a holistic perspective. So if they said their sleep is not great, I'm going to make sure I give them a little bit of a sleep education. And then in my note that I write that they can see via my chart, I can have my specific recommendations, just some additional information on how to, create it. What is good sleep hygiene? What does that word mean in general, right? And then
Mhm.
if there is some problem solving that we do during that appointment, I'll have those recommendations written in there, whether it be mood related or, just some executive functioning in terms of planning and remembering to take their lunchbox out or remembering to complete their homework on time, things like that. So I will add those pieces in along with the results from the targeted cognitive screener.
Okay. And this is also kind of what you had already mentioned, but we were curious a little bit more about how your three-tiered risk management system, how that might impact the recommendations that you're giving to patients and families.
Mm, that's a good question. Maybe that's another research project to see how, what are patients and families' perceptions of tier two recommendations versus tier three, which ones are more helpful, who wants to
Mhm.
collaborate. I think, they're going to be different because you're gathering different levels of information and different depths of information. If I'm doing the comprehensive evaluation, I may be diagnosing a reading disorder. So obviously, I'm not going to be able to report on that in the tier two level. So I think that tier three is going to be more targeted because I have more data to work off of, but tier two is still beneficial because it's giving patients and families something to start working on in some type of information and psychoeducation to have a better understanding or idea. Or at the very least, they start talking to their schools and say, hey, we're going to have a neuropsych evaluation with this person in a couple months. So can we get this process started? And I think that that is the beauty of these tiered levels and allowing for different levels of care because we can get something started earlier rather than later.
Mhm. That is, I think that makes a lot of sense. And that's one of the major barriers that we have at our clinic as well, is trying to get the ball rolling. So having it started early, that can help our patients hit the ground running. I realize it's the top of the hour. Do you have time for just one more question?
Yes, I can take one more question. Hopefully, it's not a
Yes.
tough one now that I've said yes.
One of our attendees was curious if you could speak to some of the earlier signs or some of the more subtle behavioral changes
Mm,
that you've noticed, behavioral or cognitive changes that you've noticed while working in this population.
oh, I think based on the treatment impact, especially affecting the white matter tracts, whether that be the corpus callosum or more frontal white matter tracts, you do see slow processing speed, um, reduced initiation, so taking a longer time to get started on things. They may just be slower moving physically. And you kind of see the zoning out sometimes. It's not like an ADHD necessarily inattentive, but a little bit more of that cognitive disengagement syndrome that we're hearing more about. So some of those features you tend to see. But again, every patient is different. Sometimes I see patients who don't have a predisposition for ADHD based on their genetics, and they're showing more of a cognitive disengagement profile, while you have a patient who has a strong family history of ADHD and they're showing you a little bit of both. So it's definitely unique to each patient, but I really do feel that the white matter injury, it tends to be the most notable that I've seen so far. And I'm early. I would definitely defer to people in the field that have been doing this for years and years. But yeah.
Well, that's very helpful. And thank you all, or thank you very much. And thank you all for attending Dr. Rettig's lecture. And please join us again soon for our next series. No Neuroanatomy will be starting this summer, and we look forward to seeing all of you there.
Thank you so much. Take care.
Thank you.